we get the diagnosis wrong or the management wrong, there's a significant proportion of the population that will go on to lose their limbs. But one could argue that, okay, that is not a huge problem. But now, bulk of the peripheral vascular disease that we see in Sri Lanka, it's about 60% to 80% of peripheral vascular disease is associated with diabetes. Now, if you have a situation where the peripheral vascular disease is associated with diabetes, and you lose the leg, how we define a cancer, how bad or good it is by the what's the 5-year survival. Now, if you have a pancreatic malignancy or lung malignancy, the 5-year survival is around 5% or 10% or less. 90% of the patients who get such malignancies will be dead in 5 years. Now, if you put losing a limb, like a below knee amputation and above knee amputation in a patient with diabetes and peripheral vascular disease, you're going to have a 66% 5-year mortality. So if you compare it to a cancer, it is the third worst cancer you can have. Even colorectal cancer, the 5-year survival in the latter stages is better than this. So if you lose a limb, if you see a patient with below knee amputation or above knee amputation due to diabetes and peripheral vascular disease, the chances of him being alive in 5 years is only 33%. So having said that, hence the importance, but the difference between cancers, if properly recognized and managed properly, we can actually save limbs from being lost. Now, the peripheral vascular disease or occlusive arterial disease can present in 3 different ways. One is claudication. Second way it can present is rest pain. Third way it can present is tissue loss. Tissue loss meaning gangrene or an ulcer. Now, one by one, I'll be taking cases and seeing how we can get about diagnosing and managing these patients. Let's take one patient, male, 65 years. This is a patient who just came to clinic another day, a similar patient with left leg pain on walking. Now, he says he is not significantly disabled, but because he was told to come with the family, the problem is he has to stop when he walks for about 100 meters, he has to stop. And then when the pain goes off, walk again. So now, other features is he didn't have pain at rest, there was no ulcers, he had diabetes, hypertension and ischemic heart disease, and he was a smoker. Now, how do you get about assessing, clinically evaluating such a patient? Now, what we need to do is, in the history, go through the presenting complaint and its progression and localization of the lesion. Now, what do I mean by that? Now, presenting complaint is leg pain. Now, when did it happen? Whether it's a recent, if it's within 2 weeks, you should be alarmed whether there's an acute event that has thrombose. But usually they come months later. But if it is acute, then they need, if it's within 2 weeks, they need urgent referral to a hospital, because sometimes you can lyse these clots or we can extract these clots, even though it's like acute on chronic, meaning that this patient was building up, suddenly he presented. Now, let's consider a situation where this patient had for 6 months, then you must take the initially, if it was 500 meters, then within 3 months became 400 meters, and now with its 100 meters, then it doesn't look good. So the progression is important. The next thing what we need to do is we need to check whether now this is an anatomical structure, the arterial this thing. So you have your aorta, you have your aorta, you have your iliac vessels, you have your femoral vessels and popliteal and the tibial vessels. If you remember the anatomy coming down to the foot, we need to check where is it blocked. Now, for example, having calf pain, uh, you should have is very non-specific. Any artery above can be involved. Aortic occlusions also cause calf pain. Femoral occlusions also cause calf pain. Popliteal artery also causes calf pain. However, if it is the thigh is claudicating, then you know it's femoral or above. And if the buttock is claudicating, you know it is iliac or above. So you need to ask questions like, is it associated with thigh claudication, whether it's associated with buttock claudication. Then also, now the by definition claudication is you have to stop walking due to pain in the lower limb, and following that you walk again when the pain disappears. But there are many causes of such pains. One cause is venous claudication, other cause is neurogenic claudication. But to differentiate these two on the history, how you ask is, what you ask is now, if it's venous claudication or neurogenic claudication, the pain always is more than 5 minutes. Whereas in arterial claudication, you stop walking, the pain disappears within 5 minutes. Whereas venous claudication, even if you stop, the pain is still there till you sit and raise the leg up. And in neurogenic claudication, you have to bend forward for relief. So then, and it takes a longer time. Also, remember, atherosclerosis is the commonest cause for such occlusive arterial disease. Then we need to, you can't just manage the leg, you have to holistically manage this patient, because the life is more important than the limbs. For example, you can have heart disease associated with coronary vessel disease. You can have carotid artery disease, or in the brain, strokes. So you need to take a history whether they have TIA, strokes, amaurosis, fugax, that is transient blindness of the eye, which are giving clues to, or transient weaknesses which they have ignored. Sometimes they may have a transient weakness of one side and then they have recovered. So they may not attribute because they are normal now, but this may be impending stroke. So we need to check effect on other vessels. Then comorbidities and risk factors. What are, whether he's smoking, whether he's hypertensive, whether he's diabetic, whether he's having dyslipidemias, so that we should manage all this, because once we manage all this, is only because treatment of the peripheral vascular disease actually is a very small component of this whole thing. Now, also pre-morbid condition, that is before he got this, how good he was, the social support he was. And now, since this is claudication, we need to, now only medical management is enough, because there are we don't need to intervene a lot if he's not disabled. What do you mean by this word disability? That is what the patient can't do now, what the patient was doing earlier, depending on the disease. So, for example, due to the disease, now if the patient says, I could go to work earlier, but I can't work now because of this problem, then he's disabled. He's economically disabled. They may be socially disabled. One person may say, I used to take my grandchild to the Montessori, but now I can't take this child because of this problem. I love to do. They are socially disabled. So if the patient is disabled, then you will offer a quicker form of therapy, which I'll come to shortly. Okay, so in the history, these are the important things. So, then in the examination, what are we going to check? Observable clinical evidence of peripheral vascular diseases or structures in the leg that require blood for its growth. gets wasted because you nails require blood, hair requires blood, uh, uh, muscles require blood, skin requires blood. So there will be skin wasting, meaning it gets thinner and thinner and shiny. Muscles waste and the calf girth gets less and is very thin to see. There is hair loss and dysmorphic nails. There may be ulcers. There is gangrene, which is black. I'll show you photographies later. Now, I know that this patient is claudicating, but you must look for all these. And you must examine pulses. Don't forget there is 7 pulses on one side that you have to check, because the radial, because this is a full vascular tree you're examining. Examine the radial pulse, the brachial pulse, the carotid pulse, femoral pulse, popliteal pulse, and uh, the posterior tibial and dorsal species pulses. And also listen for bruit in the femoral, renal, and the carotid areas. But that may show, even though there's a pulse, there's turbulent flow. So you must listen to these bruits. How you surface mark the renal arteries in midpoint between the ciphisternum, 1 inch laterally. Relevant general examination would be nicotine stains, then in his nails, then arcus, xanthosema, things, features of that. So this is what you should do in your examination. So now once you have clinically evaluated this patient and then come to a diagnosis, then how do you manage to treat him? Now, you have to do the risk factor modification. You must he should stop smoking, control of diabetes, hypertension, and then ischemic heart disease prevention of. Now, let's say he didn't have ischemic heart disease. These all patients with symptomatic peripheral vascular disease should have an aspirin and a statin minimum. And if they are not, they don't tolerate aspirin, you can give another type of antiplatelet like clopidogrel. And walking exercise should be instituted, because walking alone with cessation of smoking improves your claudication. Usually within 1 year to 2 years, there will not be any pain on walking. Basically, what we are saying is the claudication disappears. So how do you, they have to do a brisk walk for 1 hour. That is, then the patient will say, I can't walk. You say, no, you walk rigorously for about as much as you can. When the pain is excruciating, you stop. When in 5 or 2 minutes, whenever the pain is not there, you walk again and stop again. Walk, stop, like that for 1 hour. And you need to walk like this for 3 days per week. So basically, out of a week, there is 3 hours of walking exercise. If this patient does this, over time, the claudication distance increases to the point he will walk the whole hour without stopping. Initially with 100 meters, then it will become 200, 150, 200, like that. And we, like I said before, start low dose aspirin and these patients should be followed up. Now, another thing to remember is, now if this patient was disabled, then we would have done something else. That is, now the problem is all patients can't be put on walking therapy and only medical therapy, because some of them are disabled and they may lose their jobs. They need to get back to their lives where they were before. Then interventions are instituted. That is how you correct these things. It's with bypass surgeries and angioplasty and stenting, which we'll talk about later. So usually most claudicants, we will not operate or do any intervention because associated risks, because there is about 3 to 5% ischemia, MI event rate when you do about 100 revascularization procedures. And even angioplasty is not risk-free. Occasionally, you'll have a person, very rarely, going into renal impairment due to this. So we will intervene only if they are significantly disabled. But a very important fact we have to tell these patients who are claudicating is how to look after their feet. Because if they look after their feet well, you will not get ulcers, because if they get an ulcer, it